God. Hi everyone. Welcome back to EKG Land. In this episode, we have an EKG challenge. Let's go through our today's challenge. This EKG belongs to a 47-year-old female, known case of panic disorder and hypertension, presented with irregular heartbeat and weakness. In physical examination, her heartbeat is obviously irregular. An EKG is obtained. What do you think about the underlying cardiac rhythm? Does it require any immediate medical intervention? Let's start interpreting this EKG strip, using the classic 10-step approach we talked about in the first video. First, check the EKG speed and voltage using the standard values or calibration marker. As it is clear, the calibration marker is one large box wide and two large boxes tall. On the other hand, the EKG speed and voltage are 25 mm per millisecond and 10 mm per millivolt respectively, therefore the strip is standard. Second, determine the cardiac rhythm. As we already said, there are three main steps to interpret every heart rhythm. 1. Locate and examine P-wave morphology. As we said before, the best leads to determine the P-waves are D2, V1 and other inferior leads. Here in V1, P-waves are clearly visible. As you see, the P-waves are identical and positive in D1, D2, V3 to V6 and negative in AVR, therefore P-waves are originating from sinus node. 2. Locate and examine QRS complex morphology. Here, the QRS complexes are wide and identical. 3. Describe the relationship between the QRS complexes and P-waves, using PQRS ratio and intervals, including RR interval, PP interval, and PR interval. Here, we have non-conducted P-waves, implying that a sort of AV nodal block is present. So, PQRS ratio is variable because of the dropped beats. On the other hand, the PP interval is relatively constant, about 17 to 18 small boxes, while the RR interval is irregular. The PR interval is not stable. As you see, the PR interval prolongates progressively, and finally terminates in a dropped beat. The PR interval is shortest immediately after dropped beats, but is longest immediately before dropped beats. These findings are compatible with Mobitz type 1, or Venka back block. Third, calculate the heart rate. Since the underlying rhythm is irregular, count the number of complexes within 6 seconds, that is 30 large boxes, and then multiply by 10. Here, are 6 QRS complexes in 30 large boxes, so the heart rate is approximately 60 beats per minute. Fourth step is axis analysis. Here, the QRS is negative in D2, and positive in D1, therefore we have left axis deviation. There are many differential diagnoses for left axis deviation, including left bundle branch block, left ventricular hypertrophy, old inferior MI, WPW syndrome, left anterior hemiblock and so on. We will elaborate on the cause of axis deviation in later videos. In this strip, left axis deviation is due to left anterior hemiblock. Fifth step is examining the P-waves. Here, the P-waves are sinus. As you see, they are bifid in limb leads, and more than 3 small boxes. P-waves are more than 1 mm deep in V1 as well. These findings are highly in favor of left atrial abnormality. Sixth step is PR interval. As we already said, the PR interval prolongates progressively, and terminates in non-conducted P-waves. The PR interval is shortest immediately after dropped beats, and is longest before dropped beats. These features are mostly compatible with Venka-Back AV block. Next step is QRS complexes. Always examine 4 items to interpret the QRS complex changes. 1. QRS duration. Here, the QRS duration is 3.5 small boxes. So, the complexes are wide. There is prominent R in V1, with slurred S in V6, which is compatible with right bundle branch block. 2. QRS amplitude. Here, the complexes are more than 5 mm in limb leads, and 10 mm in precordial leads. On the other hand, no evidence of ventricular hypertrophy is present. Therefore, the complexes are neither high nor low voltage. 3. R wave progression and transition zone. Here, all QRS complexes in V1 to V6 are positive, and no transition zone exists, so we have positive concordance that is due to right bundle branch block. 4. Look for pathologic Q waves. In this strip, there are isolated Q waves in D3 and V1. Isolated Q and D3 is a common finding, and considered as normal variation. QR pattern in V1 is due to RBBB as well. Therefore, there is no pathologic Q in this strip. In summary, QRS complex changes are due to right bundle branch block. Next part is examining ST changes. Here, the T waves are positive in all leads except V1, D3, and AVR. There is no particular ST elevation or depression. So, there is no significant STT changes. Next part is QT interval. Here, the QT interval is about 11 small boxes, so the QT is 440 millisecond. The heart rate is 60 beats per minute, so according to the Hodges formula, the correct QT interval is 440 millisecond, and therefore is normal. The last part is overall interpretation. Before going through this part, if you have enjoyed this video till now, please subscribe me and ring the bell for further videos. To interpret our EKG properly, we are supposed to make a list of abnormal findings. In this strip, the abnormal findings are, vent Quebec AV block, left axis deviation due to left anterior hemiblock, mitral P wave indicating left atrial abnormality, and right bundle branch block. The presence of right bundle branch block, with left anterior hemiblock, and first or second degree AV block, indicates possible trifascicular block. Therefore, this EKG is sinus rhythm with possible trifascicular block and LA abnormality. Note that presence of right bundle branch block with LA abnormality is suggestive for underlying left ventricular hypertrophy, so echocardiography is indicated. On the other hand, the underlying block may be the cause of weakness in this patient. So, further evaluation and cardiology consult is necessary. But in my opinion, urgent hospital admission is not required in this patient, because vent Quebec AV block is a benign heart block, and usually does not progress to higher blocks. Thanks for watching this video. If you enjoyed this video, please subscribe me and ring the bell. Have fun.